Good evening, one and all. Thank you so much for coming in big numbers for the new launch, new venture from online dentistry called Case Discussions. Give us a couple of minutes more. Let's enter more people. More people are coming in. Waiting room is kind of stuck, I would say. Give us a couple of minutes more. We will enter all and we will start immediately. Good evening. Give us a minute more. Let's enter all into Zoom. We'll start immediately. Give us a minute more. Thank you so much for your patience. Thank you so much for coming in so early. We had people waiting all the way from 7:30 onwards. Thank you so much. 8:03. Joe, is it stabilized? Zoom stabilized? YouTube?
Yes, it is, sir.
Perfect. Thank you very much. Good evening, one and all. Welcome to Online Dentistry. Welcome to yet another free webinar by Online Dentistry. Free webinar by Online Dentistry is now almost nominated to Limca Book of World Records for the maximum number of free webinars in the lockdown period starting from March 23, 2020 to today. Thank you so much for the support. We started with 2 groups and now we have more than 160 groups with a lot of enthusiastic dentists, a lot of support all around the world from 44 countries. Thank you very much. Online Dentistry firm started way back in 2008 with the motto redefine dental education, and we did exactly that. We redefined the way dental education is done for private practitioners, because many private practitioners thought that education is stopped, done once you graduate. But we changed the way dental education is possible for the practicing dentists. We moved slowly towards postgraduate students, postgraduate training in multiple subjects, and then recently 2 months before into undergraduate training called Exam Alert, wherein we have final year, all subjects of final year covered with 10 short notes, 3 short essays, all covered by eminent faculties on all these final year subjects, and slowly spreading that to 3rd year, 2nd year, and 1st year as Exam Alert. And now today it's a big day for Online Dentistry. We are launching a new concept called as Case Discussion. Case discussion is nothing but presenting a case from beginning to end. Anybody can present. Just like publishing a case report in an article, you can present a case in our platform. The moment you have beginning to end, whether it's perio, whether it's prosto, doesn't matter. We are giving a possibility to present your case from beginning to end. Thank you so much for the support shown to our program. Online industry started way back in 2008. Many people thought that we started when the online thing came last year. No, we started in 2008 with the name online industry, with the domain www.onlineindustry.in way back in 2008, with our offline courses, offline programs for our candidates, learning 3 full days on myofunctional orthodontics. That is how we started. But we had online email stuff, the study material, assignments and all that going through email. So we called it online industry way back in 2008. And you are right. Last year, during the pandemic, we really became online. I would say we became only online. Offline courses are stopped for the time being. Myself, Dr. Binu Abraham, orthodontist, practicing in Kochi for the last 22 years, and my partner, Dr. Jobby Peter, my clinic pediatric dentist, we both formulated this whole concept called as online dentistry way back in 2008. We presently has 10 centers all around India. So 20 candidates ready to learn myofunctional orthodontics in Delhi. We go to Delhi. But like that, we have 10 centers all around India at this point of time. But at this point of time, we have suspended all our offline courses. We are going to resume our offline programs at the earliest, as soon as we get some relief to this pandemic. Let's hope and pray that we get out of this at the earliest. Presently, what we are doing is like 1 hour free webinars and 3 to 7 hour paid webinars. 1 hour free webinar. The one you're attending tonight is part of that 1 hour free webinar. And that is the one being nominated to Limca Book of World Records for the maximum number of free online programs during the pandemic for the dental fraternity. And then the paid webinar. 3 to 7 hour paid webinar. Just finished one program 30 minutes before. Started all the way at 10 a.m., 10:30 a.m. Finished just now. One full day on clear aligner technology for private practitioners. So these are our paid programs happening parallelly. Many free programs coming up, all about local anesthesia coming up, right from loading the syringe to where to inject coming up, orthopedic movements, headgears, protraction face mask coming up, chin cups coming up. All a dentist should know about orthognathic surgery coming up by one of the finest oral and maxillofacial surgeon, Dr. Sherry Peterson in Aster Medicity, Kochi, coming up soon. Proud to announce our association with Lincoln University, Malaysia, Faculty of Dentistry, Lincoln University, Malaysia. Extremely happy and proud to be associated with Lincoln University. We are launching our first program under the banner of Lincoln University. That is next Sunday, 7 days from today. We have the first program under the banner of Lincoln University. Thank you so much, Lincoln University. Dean Pushparajan sir, Associate Professor Gobu sir. They are all here as guests tonight. Thank you so much for coming in. Thank you so much for that collaboration. Thank you so much for trusting online dentistry. Sir openly told they were searching for some affiliation with India, and they found that this is one for their strong in online at this point of time, and they're good in offline too. Thank you so much for trusting us, sir, and inviting us and getting this collaboration through. So first program coming up next Sunday under the banner of Faculty of Dentistry, Lincoln University, complete 1-day program on interceptive and preventive orthodontics for your pediatric cases. You will never say to your patients, come back after the age of 13 years after attending Dr. Jobby on this day. You will never tell parents, oh, it's okay, you can treat it at the age of 13. You will never say that. At the age of 6. At the age of 7, you see a malocclusion, you start treating. You start at least identifying the cause of it and treat the cause of it after attending this program. CPD, the Malaysian points, CPD points being awaited should be through within days. So that is about the Malaysia program. And then we have the Dean of Lincoln University, Malaysia, Professor Dr. Pushparajan sir, is here as a guest. Going to enlighten 2 minutes about Lincoln University, about his experience with online dentistry, and about you guys listening to me, what advantages you have being associated with Lincoln University and the value of that certificate which you're going to get next Sunday by attending this program. Also, we have Associate Professor Dr. Gopu. He's also online here. Thank you so much, both of you, for coming in as guests into our platform tonight to highlight about that collaboration which we had with Lincoln University. Let us hope and pray that we will meet up soon in Malaysia with an offline program also as soon as this pandemic gets over. I called Dr. Dean of Faculty of Dentistry, Lincoln University, Malaysia, Dean, Professor Dato Pushparajan sir, to speak few words about this collaboration. Thank you, sir. Please, over to you. So you have to unmute, sir. Yes.
Thank you, Dr. Binu, for having given a wonderful introduction about the online dentistry as well as the Lincoln University. And I should thank Dr. Joby Peter also. I have been associated with these 2 eminent personalities right from the time when they had the fully black hair. Now everything has turned into white hair. It shows the wisdom that they have gained or which they have taught to the students. So I'm really very thankful to Dr. Bino and Dr. Joby Peter for having a tie-up, for having a collaboration with the online dentistry with our university. And I have to say something about our university also. Our Lincoln University has got about 140 programs with us, and one among them is the Faculty of Dentistry. And we are having the DDS program, that is Doctor of Dental Surgery, where we follow probably the American pattern of systems. And most of the BDS programs, I think, are following the British systems. Okay, so in India also, see, we have got the BDS, but not everybody can afford, or not everybody get a chance to do the Master of Dentistry program, Master of Dental Surgery, or whatever it is in India. So for not only for Malaysians, it is open to international students also. We have got the postgraduate Master of Science in Dentistry and the PhD program, which is a research-oriented program. This Master of Science in Dentistry is a 2-year program, and PhD is 3 years program. It is open for both bachelor degree holders as well as the master degree holders. Okay, and more so, this is definitely an advantage for the students. I mean, who is just stopped their academic curriculum with the BDS program. Somebody may be interested to do the practice. So once they start the practice, they may not have the time to do the master programs. So for all those people, if they want to acquire a master degree, which will definitely decorate the board as a private practitioners. I mean, nowadays, everybody see what this man is having. Is he a BDS holder, or is he having any master degree? Is he a PhD degree? And is he holding any Royal College? If not, at least some master programs. So those who cannot get a master degree, Master of Dental Surgery in India, or any other countries for that matter, even in Malaysia or in any other international level, we have got 2 wonderful programs, that is Master of Science in Dentistry and PhD also. And this is regarding our postgraduate program that we are having, because India has already a lot of dental colleges, so I don't think they need to have any introduction about the dental program that we are conducting. But I would like to say a few words about the medicine. You see, I believe in India, the cost of doing the medicine has become very expensive. It is touching almost about a crore of Indian money, and it's really heavy money for an average or a middle class student, for whom probably doing a medicine may become a dream. So for them, you see, now the door is open in our university. You see, now for India and certain other international countries, we are recruiting the students for the medicine. That is, we follow the American pattern. That is MD program. We are not called as MBBS. We are MD program. You see, it is also 5.5 years program with 1 year housemanship and all those things. So it is a 5.5 years program. Okay, the cost is very, very nominal when compared to India or certain other countries. It may go about, according to the Indian money, it is about 5.5 million. That is about 50 to 60 lakhs, I think. Yeah, 50 to 60 lakhs. I mean, this includes all your 5 years examination fees, your hostel fees, your your mess expenditure. If there is no mess arrangement here, you can go to either the hotels nearby, or you can go to some of the restaurant nearby, and or you can cook yourself, because our hostel facilities, you see, it is about 2 rooms, 3 rooms in a apartment, which will have all the cooking facilities also. If any of the students want to save the money, yes, they can cook themselves. It is going to be very, very cheap also. Even eating outside is going to be very cheap for them. Okay, this is just an introduction about the medical program that we are having, where students cannot study by paying the hectic amount in India. They can probably prefer this one also. This is, and our students are authorized to write the exam in US also, and we are giving the training also. And shortly in dental also, we are planning to start Master of Science, I mean, in clinical areas, 1 year program. But it's yet to come. It will take some time for us to prepare all the documents and get the permission. It may take about a few years. But otherwise, in Malaysia, the master program is a 4-year program. That is 1 year master program plus 3 years of doctor of orthodontia, or a doctor of periodontia, or doctor of oral surgery, something like that. Okay. So with that 1 year also, you will be getting a master degree. So that is likely to come very shortly, but that may require about a bit of a clinical training also, where probably you may have to come over here. And this is all about the Lincoln University. And I'm really very happy and proud to have a tie-up with the well-reputed, well-recognized, long-standing, academic-oriented private organizations like Online Dentistry, and like how we have some other collaboration also with some other areas for laser dentistry and some of the other programs. And equally, we are very happy that we have been associated with these 2 eminent people who have turned their hair from black to gray to as a sign of their wisdom. And I really thank you, Dr. Bino and Dr. Joby sir, for having given a chance to elaborately speak about my university, about our collaboration with the Online Dentistry. And also I should thank my deputy, Dr. Gopu, who has always been guiding me in a lot of areas. Thank you very much, Dr. Bino, Dr. Joby. Thank you all. Thank you, students.
Thank you so much, sir. Thank you so much. That was so nice of you to talk even about the future programs that these people who are attending. There are many students attending. There are many interns attending. Thank you so much for that. And Dr. Gopu, 2 minutes quickly. Associate Professor of Faculty of Dentistry, Lincoln University, here with us live. It's too late at night for them, I know. Thank you so much for coming in. 2 minutes, sir. It's yours.
Thank you very much, sir. And I welcome everyone to be on this board. I'm really happy to see around 140 participants eagerly waiting to listen from Dr. Binu and Dr. Joby. In fact, I am the 141st visitor here to do that. I have heard a lot about online dentistry, and during our collaborations, we have discussed a lot, we have worked a lot. As this motto of online dentistry goes into it, that's redefining dental education. We in the Faculty of Dentistry from Lincoln University College wanted to redefine lifelong learning. So when we were exploring about joining hands with people who have like-minded achievement, we came across online dentistry. I really need to appreciate their effort. They have been working really hard behind the scenes towards enriching knowledge to all the people in our field. So with this, I hope we can proceed further and make our collaboration much success. So I really thank everyone of you here and hope to meet you back on 18th July 2021 to be on our first paid webinar to show that we are towards redefining lifelong learning in dentistry. Thank you, sir. Thank you, everyone. Do hope and enjoy.
Thank you so much, both of you, for coming in late night in Malaysia. Thank you so much for coming in and enlightening about the future prospects about Malaysia. Thank you very much. So now it's time to invite the speaker of the day, Dr. Joby Peter. And when I say speaker of the day today, it's more than Dr. Joby speaking. It is actually a discussion that is going to happen. The new branch of online dentistry launching tonight called as case discussion branch, wherein you can discuss cases. Dr. Joby is going to discuss his own case, 6-year to 13-year complete management of a pediatric malocclusion. Please listen to Dr. Joby, one of the finest pediatric dentists, one of the finest speakers, great orator, international speaker, author of textbooks, and author of multiple articles, national and international. Over to you, Dr. Joby.
Thank you. Thank you. Thank you so much. Thank you, Pushparajan sir, Gobu sir, for giving a wonderful introduction. Thank you, Dr. Binu. I hope I'm audible. My slides are visible. Can I get a thumbs up from all the audience? Can I get a thumbs up? Can I get a thumbs up? Am I audible? My slides are visible. Can I get a thumbs up? Yes, 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 yes. Great. It's a great unity between online dentistry and Lincoln University. We are working on to international and ethical and professional standards. We need that in our private practice or an academic. That's the future. Thank you so much for trusting us and inviting us and collaborating with us. We will do the justice to whatever norms and deems you say. So today's topic is entirely different from what we have been doing all these days or years. We can talk about it. It's a pure clinical case discussion. And clinical case discussion in general dental practice, it requires lots of preparation. So I have to go back to maybe 7 to 8 years to start collecting my old patient's picture. During which those times there was when digital, it's like today nowadays, like of camera was not available for me in my clinical practice, but I tried my level best to show you the best pictures of those times, and you can clearly see how transformation, how evolve the practice when I show you the picture maybe 8 or 10 years back, and that patient is still with me, and I'm going to show you those pictures of that patient. So this meticulous, uncooperative, unrelentlessly following protocol of some patients, I'm going to show you that. So, oh wow, donuts. Who doesn't love donuts? At this wee hours of night, if you want to have a donuts, definitely. Now, my thing is, there were two seeds, two seeds were there. They were good friends. They were pals each other. And these two seeds were hiding inside the ground. They were hiding inside the ground. Okay. But one seed said, no, 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 this is not that. Let me go. Let me go out and explore. He decided, let me grow up. So he decided to grow by himself. He sprouted. He starts spreading his leaves. He didn't care about anything. He started growing. And after years, he became a beautiful tree which gave so many fruits to everyone in every aspect he grew. What about the other seed which was along with him? They were pals and friends. What happened to him? He decided to stay there. He didn't take the risk. He said, if I grow, somebody will come and pluck my leaves. Somebody will eat me. Animals will come.
Jogi, sir?
Am I okay?
Yes, sir. Now you're audible, sir.
Earlier I was not.
Sir, just 2 seconds back, sir, you got muted, sir.
Okay.
Don't worry, sir.
Fine. So this seed was hiding himself inside, not ready to come outside, not ready to sprout, not ready to see the risk. You know what happened? Sometimes after that, what happened is a bird came. He was just searching for food and finally found this seed and it ate that seed. Done. Over. So why did I say this story of two seed here is risk in life is one that you should take. Take risk in your life. If you win, you can lead. If you lose, you can guide. That is risk in life. You have to take the risk. If you do not take the risk, over. If you take, you win, you can lead. If you do not win, also, you can guide, guys. Please, dental practice or your profession, you are chosen. In any profession you are, you need to take that risk. And that can change your life if you trust in yourself. Myself, Dr. Joby, as you said, work in Anu Dental College, Moatubura, and my principal and my team. And thank you so much for the support. If you are anytime, if you want to interact with us, you are always welcome to our institution, Department of Pediatric and Preventive Dentistry. Now, this particular is a case discussion. This is not going to be like theory kind of thing. It's going to be case discussions. There are two patients sitting in front of you who has got a problem. So one patient says that my daughter's teeth are crooked. They are not coming in right position. Other patient says the teeth are irregularly coming. One is crooked, one is irregularly coming or coming out. That is the condition there. So if you see both these two cases, what will be you do in your clinic? See, please be, it's a clinical case discussion. It's no theory involved in that. It's a pure clinical case discussion. So if a patient comes to you with crooked teeth are coming out, what will you do? Or if another patient coming, their teeth are coming out, what will you do in your practice? Can I know in the chat box, what will you do in these situations? Please tell whatever you feel. Use the chat box. Don't be bored on sleep. Just see what I will do if this kind of two cases comes into my clinic. What I will do. Okay, refer to orthodontist. Good, good, good. Oh, amazing. Wow, I'm bombarded with chats. Refer to orthodontist for consultation. At patient's age is only 7 years. You refer to orthodontist, fine. Radiograph, arch expansion, radiograph for investigation, case history, orthodontic treatment, ortho case, model analysis, patient history, age. I already 7 years, 7 years. As it was a growing age, we would wait. And arch expansion, ortho, refer to orthodontist, say serial extraction, arch expansion, great. Amazing. I'm bombarded with answers. I salute your answer. I salute your answer. Whatever you have talked is from your perspective, your thinking level, from your scenario, you expressed it. That is what I tell you. You express, you feel. tomorrow, if I get this patient, this is what Dr. Joby, I'm going to do this. You express it. I can change you. I can change you. I can change your life if you express it. If you repress it, I cannot. I cannot change. So that is why I requested you to put what you feel about it. It is going to change your life. So in these two conditions, you are going to do one of these things that you said. Okay. And let me tell you, you are done a very great job at this point of time from the understanding of these cases, because I did not show anything more than this, but you at least said some genuine ethical thing. You did very good. I really salute for that, what you have done there. Now, I just want to show you that we have to be ethically and professionally. So definitely the first patient which I've shown you, as his patient names is Fida. Her age is 7.5 years and it's a female patient. So her chief complaint or her mother's, a 7.5-year-old never come and sit in front of you. Doctor, I have a tooth which is rotated or tilted or coming out, never will say. So it is parents. This is your first understanding. This is parents' worry, parents' query, parents' doubt. So that is first thing that you have to understand. How many of you have thought about that first? That, oh, it is not the child's demand. It's the demand, worry, query, doubt of the somebody else, other person. Who's the third person? Parents. So now you as a dentist, you have child as a second person, and you have a third person called parents. So this chief complaint is at this 7.5 years of age is by the parents, not by the child. Very rarely you can get that. But in this condition, let me tell you, this child, now let's be very practical and honest with you. This child of 7.5 years was the worry for the parents. Child was literally worried about that tooth coming out and she could not even smile. I'll talk about it there. So interceptive and myofunctional orthopedic diagnosis and a treatment plan requires a detailed planning before starting it. You need a definite protocol before starting it. Then you can become master in that. If you blindly start after seeing the, okay, complaint is this, let me start with arch expansion. Complaint is this, let me break the habit. Complaint is this, let me refer to orthodontist. Complaint is this, if you do those kind of things into a patient that is coming into your clinic, let me tell you, that patient is not going to come back to you after this. Because you did not have a format, you did not have a protocol. Yes, you come to me, I will guide you. They want your guidance, and now you are trusting onto somebody's guidance, which you do not know how genuine ethical it is. In your clinic, let me tell you, if I want to convince a patient for implant, I am the master. I tell this can be done implant. If I feel it cannot be, this is not case for my clinic, I will send anybody. I am not bothered. If this is a perio case, I will call the specialist. I will tell them this is a case that has to be done. And I will tell, work as a team. We collaborate and work as a team. This is a good case to be done. Patient is happy, you are happy. They are so trusting in you. That is the mistake we do. Whenever you see a condition, rougher, please, no. You analyze, you find out, yes, this has to be done. That is a good ethical professional, and your clinics will prosper. Even if you are not there, your juniors, your assistants, they will work according to your frequency and they will sustain it. Believe me, in my clinical practice, let me tell you, it works wonders there. So this case, the case which I told you, let me show you a picture. whenever if you are seeing or if you are trying to do any kind of appliance therapy or any kind of interceptive or preventive orthodontic, I am talking about interceptive and preventive orthodontic. like you want to give a space maintainer, hold the dental arch, or you want to give any removable or fixed interceptive or preventive or habit breaking appliance, please, I beg your pardon, please check the caries status of the patient. Nobody in this told about that aspect at this point of time. Nobody observed it, but nobody told also. But let me tell you first and the foremost thing, you should be, if you are applying or if you are taking an impression, sending it to the lab, or you're fabricating any additional apparatus inside a patient mouth, first and the foremost thing, believe me, an ethical professional practitioner should be doing is caries status of that patient. If you are not doing it, you are not doing ethical practice. I can come to you, stand here and tell you, if patient has got caries high activity, you are not supposed to do a fixed appliance in that patient. Removable, if you are doing it, okay, you can search anywhere, even the textbook of orthodontics, so-called any textbook you see, risk with fixed appliance, they will tell you, yes, every fixed or removable appliance you are giving onto your patient, it has got its own risk. So check out that. I cannot do a expansion appliance or a fixed orthodontics in this patient. I cannot, because of his oral hygiene status there. I cannot do that. I cannot do that. I am not injustice to do this. If I put brackets onto this, that patient will end up in something else, which, look at this. Now look at this. There is a fixed expansion appliance in a patient, and can you come to the chat box? What the hell this doctor has done? Is it done right thing or wrong thing here? This is right or wrong? I want your genuine opinion. Wrong, wrong. Yes, yes. Not right, sir. Wrong. I want everybody who is attending to me, please, what nonsense the doctor has done. How can he do this to this patient? Wrong. Unhygienic. Unhygienic. Absolutely wrong. Great. Oh, am I getting into you? Am I getting into you? Unhygienic. Look at the caries. Look at this. How can a doctor do this to this patient? I might be criticizing that doctor. I might be saying, yes, yes, Dr. Joby, that there should not be done like this. Correct. Very good. Now, I mean, all of you have answered and everybody is with my side. Great. Thank you for that. And at least you understood this. Now, that is great. Okay. So whenever you have a very bad oral hygiene like this, you are not supposed to do orthodontics or supposed to do interceptive, preventive, whatever kind of things, because you will end up in this if you do not follow up. You can see 18-year-old with 14 MOD caries, you will end up in like this. So it is better, or it is not indicated, oral hygiene and caries activity status has to be given there. Now, coming to this case, my dear friends, this case is being fixed by myself. Yes, myself have fixed this appliance inside this patient mouth. You can throw tomato on me. You can do whatever you want onto me, but listen to me till the last slide. I will justify you. I will tell you how clinical practice goes on. This is done by Dr. Joby. And you can tell you are a fool, you are absolute nonsense, this is not ethical, unethical, Dr. Joby, how can you do this? Yes, I am authentically telling you, start to finish of this case, It is done by me. I have done my patient, and she is my daughter's classmate. More what ethical evidence I can tell you. My daughter's classmate was this case. But listen to me till the last slide without blinking. Listen to me. What I'm going to tell you, this will be discussed, and I will show you what is now status of this child. She is almost 14 years. I will tell you that. So this is done by none other than Dr. Joby Peter only. I'm sorry if you feel bad about it, but I will tell you the reason for this. So let us come back to our case, which we put on to discussion. The case we told about that 7.5 years FIDA with complaints of irregularly placed tooth was the complaint of the patient. And the interception myofunctional chart is nowhere available. It is, we have a, you can talk about a altogether matter. We have analyzed it. We have a formulation. Step by step, we do it. And one factor will be discussed here, like function analysis. A step-by-step protocol is required for that. And one thing which I believe till now is Dr. Graeber. Sir is the father of modern orthodontics. And Dr. Graeber and Rakowski is considered to be the best textbook you should read. I'm giving you the hint. Read Graeber and Rakowski. These textbooks will give you the function analysis, but it's very difficult to understand. So there is something called habitual rest position for all myofunctional cases. There is something called habitual rest position where the mandible comes and at rest. Very, very important. Initial hint it gives whether the patient is class 2, class 1 or class 3, even without looking into molar relationship. Molar relationships are dental, but this will give you a hint where the patient is heading on to that. So this patient was normal. Any occlusal interference while closing? No occlusal interference for this patient while closing because there was no obstructing teeth present. Midline shift? Yes, midline shift was present for this patient. Habits? Any habits like mouth breathing? No, there was no particular habit that was present for this patient. So everything, if you see, I will show you the picture, then you will understand whether these things are there or not. Tongue, very important factor to see. Tongue, size of the tongue, is it normal or not? So a 7-year-old patient, what is the normal size? How to check? You need to understand that and check whether the tongue is abnormally long or short at that point of time, and what holds the tongue there, especially frenum. Frenum is the one that holds the tongue. So the lingual frenum has to be checked for each and every patient. Even if you're giving oral screen, guys, even if you're giving a space maintainer, are you checking the lingual frenum? That's very important for that. Frenum labile or buccal, very important. Now, position of the tongue. Is it retained infantile swallowing pattern? So we stress a lot onto tongue. Tongue plays an important role in development of face. So we literally screen tongue from top to bottom. Size, shape, position, function, everything has to be. So for this patient, luckily, everything is fine, but this patient had a retained infantile swallowing pattern. So now, can you come to the chat box and tell me, Dr. Joby, yes, we know that, okay, everything freedom is normal, but what do you mean by retained infantile swallowing pattern? What do you understand at this point of time when I told you it is a retained infantile swallowing pattern is there? Can you please put onto the chat box what you mean by this retained infantile swallowing pattern? Please chat, please talk about yourself, talk your heart out and tell what you felt about it. Open bite, tongue thrusting in between. Okay. Fine. Tongue comes in between. Yes. So many people have answered it very nicely. Your heart, you open it up. But let me tell you, there are some people who said about anterior open bite. No, you may not have anterior open bite. You may not have anterior open bite, but you can have a retained infantile swallowing pattern. Okay, that means you can have a deep bite, but at the same time, you can have a retained infantile swallowing pattern. Now we have a prefixed mind Tongue thrust means open bite. Tongue is coming in between, so it will push the teeth out. We learned in biology in any textbook, if you see, we learned about it. So tongue is coming in between, so there should be an open bite. No, there are difference in that. So you can have a retained infantile swallowing pattern about it. So that is what present for this girl. So this was the girl. This was the girl. If you see the frontal non-smiling view of this patient, lip posture during swallowing, it's okay. Lips parted, no, there are no lip parted there. Tonicity, you can see hypotonic lip. You can see the evertedness of the lower lip. You can see that lower lip is everted. Especially the lower lip, you can see it's a little everted. Facial type, patient is almost a mesocephalic, not too dolicho, not too brachy, almost into a mesocephalic pattern. You can see facial asymmetry, no much facial asymmetry. So everything is okay except hypotonic and everted lip. 7.5 years. Okay, so one point that you can get from this looking into this patient is your dolicho and all are not possible here. Thing is soft tissue. What is the problem with the soft tissue? If I look into this patient, the problem with the soft tissue I find is everted lip, lower lip is getting everted, dried, fine, and hypertonic it is. Okay, that is one point. At least at 7.5 years you're getting, there is a problem with the soft tissue there. Now smiling, oh my god, to make this patient smiling, as Dr. Binu said in his previous class, 7.5 to make them smile, it is not easy. I tried, and all I could get is that because she's very shy, that one particular teeth is been shown, and her friends has got 3 to 4 teeth, and she has got only that particular teeth. And that was the reason she was pestering the mother that my smile is not good. I'm ugly. Everybody is making fun of me. Please take me to a dentist. So that was one reason that she was in front of me, because of that smile. She was not happy with that smile. She was mentally, physically not happy with that smile. Very difficult to get that smile. In profile view, there's nothing at this age to see the profile and all. At 7.5, just start erupting stage. Now, this is the occlusal view, frontal occlusal view. You can see the condition there. You can see midlines are gone. You can see teeth are buccally erupted. You can see caries, all the upper arch. You can see lower arch. You can see multiple fillings are done. Upper arch again, arrested caries with multiple caries, active cariesation, all those things you can see in this patient there. Okay, so she has been visited to multiple dentists. They did treatment, whatever possible thing they did that. That is great. Salute to the dentist. At least he attempted this much to preserve the tooth. But you know, there was some grave mistake that has happened there. But oral hygiene was poor. That is why she's getting newer and newer caries. Even the 6 are getting discolored. Oral hygiene was poor. Caries is highly indexed. So if I allow her to proceed like this, definitely the permanent will also get infected, and there is crowding developing. So I have to take care of this patient's high caries status or high risk of getting caries. At the same time, I have to take care about that crowding, that worrying teeth that is coming there. Midline is deviated to the left, you can see. And when we took a history, the mother told her initial, somehow they sent a picture saying that her initial condition was something like this, doctor. It was very bad. This was a primary dentition was like this. And that retained root stem is the reason for that tooth to go buccally like this, that central incisor to go like that. This was a picture around 3.5 to 4.5 to 5 years, this picture. Now those 7.5 years it is. So that was the reason which caused this, and it is continuing it. And they are observing. Early it was a primary teeth, so they were not worried. Oh, milk teeth, it will shut off. Why you have to worry? So that was that. But when the permanent teeth started erupting, an abnormal position, crooked, twisted, turned, they started worrying it. They said, oh, we have to see something has to be done. This is exactly happened to this patient there. So go on to the analysis, occlusal relationship of this patient. Permanent molars are just erupted and they are endowed, and primary molars are in mesial step. You know, you need all about that. And model analysis. So now comes to the upper and lower impression taken. The model analysis. Overbite, if you see, it is not too much or too less. It's all normal developing. It's not very significant at this point of time. Crowding at this age, mixed dentition and lateral incisors are erupted. Crowding is an important factor. And crowding in the maxilla is 6 mm. Crowding in the mandible is about 4 to 5 mm. Reicher scale, you can say mild crowding in the lower, but moderate crowding in the maxilla. That's it. And the transpalatal width is the maxillary width from molar to molar, 6 to 6 width is only 33 mm. In a mixed dentition, it is lower. It should be around 35 to 38, but here it is only 33 millimeter. OPG. So I usually do not go for lateral ceph for 7.5 years of age, but 7.5, once you see teeth are not coming properly, too much of rotation, I recommend an OPG just to see any missing teeth. Nothing more you can see. I just want to see any missing teeth or anything, because I have to plan for this patient. So an OPG at this age, 7.5, 8 years would be good, just to see any missing teeth is present or not, or any other extra teeth is present or not. And if you see multiple OPGs, you will be able to tell that there is space deficiency by looking into the OPG. Properly taken OPG, you will be able to tell. We'll discuss at other point of time how to analyze an OPG, but an OPG is indicated there. So the panoramic X-ray that we look into missing teeth, impacted teeth, or supernumerary, root resorption, bone loss, caries teeth. But this 7.5 years, mainly we look for any missing teeth, impacted teeth, or a supernumerary teeth, but that was not there. But in a permanent dentition, you are talking about 11 after 9 years, 10, 11, 12 years, definitely you have to look for the canines. Canines are very important. We have diagnostic tools to predict the impaction of the permanent canine or difficult erupting permanent canine, but it's an older age, 9, 10, 11 years. But this child does not require that also. So the final diagnosis of this patient, if you summarize the history, if you summarize the clinical photograph, intraoral, extraoral, and the OPG, because lateral ceph is not that mandatory here. We are not classifying him to this and that because he's still the growing stage, would be a FIDA, 7.5-year-old female patient with moderate crowding in the upper arch and mild crowding in the lower arch, and having molar on one side with the end-on molar relationship. That could be a part of the diagnosis, we can say. What about the next? Midline is deviated to the left. Labally position 1-2. You can see the 1-2 is labally position. Reduced transpalatal width for this age, which was supposed to be 36 to 38. No missing permanent teeth. Luckily, there are no missing permanent teeth. Caries status is high risk with multiple active caries lesion. And functionally problem, retained infantile swallowing pattern with hyperactive perioral muscle. That is one functional problem that is present, sir. So you have identified this patient is having a crowded arch in the upper. Midlines are already started shifting. Tooth are rotated or placed thing, but luckily there are no missing teeth or no additional teeth. Caries activity is high, and there is a functional problem called hyperactive mentalis activity or infantile swallowing pattern is there. Now, can you tell this patient to wait? No problem. All are milk teeth. It is going to shed anyway. Why I want to do? Let all teeth come. Yes, all teeth will come because there are no missing teeth. It will come, but they won't come on proper position. They will come there, and you have to end up in a total orthodontic consultation there. So what can we do to avoid this? This is complicated now. You see, crowding I have to manage, Dr. Joby, and midline is shifted. Dr. Joby, I have to manage midline also. Caries is very high, Dr. Joby, and functional problems. So 4 problems for this patient. How will I do? From where should I start? Are you confused? I know. Already confused, which I will address it. If I correct crowding, what will happen to the midline? Will the midline get more deviated? Will it get more worsened? What will happen to the functional problem? The tongue thrusting. So shall I give tongue grip first and start tongue grip first and correct it? So much doubt comes there. This is interceptive and myofunctional diagnosis, that once you clearly know the problem, the priority where to start depends upon one simple example. Let me tell you, simple example. Let me tell you, you heard about chicken and egg. Chicken and egg, which came first? You tell me which came first. I am telling you, chicken and egg, which came first? Is chicken came first or egg came first? You tell me which came first. Put in the chat box. Is chicken came first or egg? Okay. Noor said egg came first. Amrita said chicken came first. Recently it was chicken. Egg. Egg. See guys, exactly now I am drawing into conclusion. You can fight each other. Chicken. Farmer came first. Okay. Farmer is the one who grows. Great. You can keep on fighting. You know where you will end up it. Nowhere you will end up it. Here I can say that Dr. Chobi, functional problem, address it first. That came first. I can argue, no, tooth is, you correct the tooth first, then functional problem. Guys, let me tell you, both are existing or coexisting. It is not both to be addressed. It is, you should know, okay, I know both are there. I know chicken and egg. I am not bothered about them. What will happen next? What is the future of this child? Okay, if I do not intercept at this point of time, this child will definitely end up in total crowding, total crossbite, collapsed arch, or proclined, or whatever. You know that. If you know that, you know what is going to end up. You can educate, motivate, plan treatment protocol. You can tell them this has to be done like this. Let us do like this. Let us do like this. Now comes Dr. Jovi, that is good. Yes, I know. But patient, parent has to accept. Patient has to accept it. Yes, you are right. You are right. Everybody who's listening to me, open up your ears and listen to me very carefully. Patient has to accept. Parent has to accept. So I can talk big things. Oh no, it has to be like this. Dr. Graeber said it is like this. Dr. McNamara said like it is this. Dr. Profit said it is like this. Dr. So-and-so said like this. You tell, but patient won't accept it. Patient won't accept it. You have to understand what patients want and what is the need. That is why one line I said, you know what is going to happen next. Patient don't know. Parent don't know. Graeber don't know. He's no more now. He don't know. Nobody knows. Who knows? You knows. So you are the master. You are the boss. You can tell, dictate terms. You are not going anything unethical because you did so many analysis. You came to a conclusion or final diagnosis, which is blueprint for you. This patient will end up here if I don't intercept him now. So let me see the patient. Let me talk to the parents. Oh, fine. Let me start this. You might start with some protocol, but patients and parents are with you, accepting your treatment protocol. Their worry or their whatever thing is addressed. But at the same time, you know that if I institute this treatment, what can happen? All precautions. You as a boss, that is called, you're a boss. You go to a cardiac surgeon, he does so many investigation. You tell Dr. Jovi, come for tomorrow. Oh, you morning, you go just like as a small kid, there's no sleeping. You go to the cardiac unit, you go to the surgery, come back and get everything done. Surgery is over, bypass is over, everything is over. Have you know how much pressure, tension, how much investigation, planning that cardiologist did for you so that you are smiling now? Why we dentists can't do it? I will show you the cases where it was collapsed. It was utter nonsense that I should attempt there, but attempted, proven, shown in front of you. See it, and you tell them what has happened there. So that was the treatment protocol done for this. And I formulated a treatment plan. I discussed the treatment plan for her. I told for this patient, you need a preventive care first. Whatever said and done, you need to do this. I elaborated the preventive care to her, explained to the parent, mother, sat with them, discussed with them, show videos, half an hour to 45 minutes. Many place I go as consultant, they curse me, Dr. Joby is coming, make it is a time duration because I spend time. I will spend time. Whoever waits, spend time. If it is required, spend time. So I usually tell them give time-based appointment, but many doesn't do it. But time is spent with the family there, in informing them, understanding them. Diet modification, brushing. You think, believe me, you think these are nonsense. Dr. Joby, it's not going to work. My parents or patients not going to listen. This is what you think. I can tell you thousand stories of parents. Nobody taught me, talk to me, Dr. Joby. He taught me this is the reason for my daughter is getting repeated caries. My child is getting that crooked teeth. My child filling is not staying. My child is in pain because of this. So it has to be done. Everything, there's a protocol. Is first is this. If it is required, this I don't have time to explain, but this is the protocol. So many times I'm seeing 9, 10-year-old after going to multiple clinics, multiple pediatric dentists. Sorry about that. We have yesterday, we had a case on Friday. Very sad to say, pediatric dentist went, but still this protocol is not followed. They hesitant, they're reluctant, and general dentists doesn't do that. So that is the one. Then come to my phases of treatment protocol. Every case first, even my postgraduate, I tell them, do this first, then take the patient to me. I will talk. If you do not, you leave that case, I will manage. I openly tell them to the postgraduate, if you can manage this phase, preventive and everything, then you bring to me. I will teach you what is phase 1, phase 2, because I know how much time I have in this. I'm controlling it. If they cannot do that, forget it, leave it. I will take care. I will manage separately. Don't come and indulge in with me. It's very open to my postgraduates or whomever listen to me. This is the protocol you should have. So then comes the interceptive part. Appliance therapy will come with, can starts with the muscle exercises or lips or to the tongue, and I select the appliance depending upon the model analysis. So some slow maxillary expansion is decided for her because of the crowding. So I will decide which screw I will prescribe to the lab. I want a screw of 11 mm. So lab knows, okay, Dr. Joby has told 11 mm means 11 mm. That is because of the planning that you need, because otherwise they will send you a lower screw, which is 9 mm is available. They will send you, but you expand, nothing is happening. No expansion is happening. You tried that, but no expansion. So they may say, Dr. Joby, you told to give a SME. I give SME, but no expansion. I said, what screw? Sir, what screw? Did you give 11 mm screw or 12 mm screw or 14 mm screw? Sir, I don't know that. I just told them to give a 2D expansion. I did it and they gave to me. Aha, that is lab is taken granted for you. So lab prescription is important, and how much duration you need. That is also important. And minimum checkup 45 days is minimum. I tell every patient minimum. This lockdown, so many WhatsApp calls and discussion because they can't come to that clinic, this clinic. So somehow manage. It was a tough time, as you all know, tough time. And but otherwise 45 days back a checkup is good. And tell them retention will be required till the permanent canines comes into stable. And patients are so happy because they can see the result. And then goes to phase 2. Once the permanent canines comes and settles down, if required, you go into phase 2, local fixed orthodontics. So all cases may not end up in non-fixed orthodontics because it's a part. It tells them, but initial stage of orthodontics will be required for that, and you save 40 there. So that is what said. So this patient, let's see this patient, what has happened. Exactly, this patient expanded the arch. 8 months into expansion, the same patient I'm posting in front of you. Look at the midline now. Aren't they coming closer? Look at the tooth which was so uprightly placed, slowly erupted. Other teeth. The lateral which was posteriorly placed, isn't it coming back? Can you see the lower anteriors already? The lower anteriors which was totally displaced, slowly getting aligned for the. This is her after the removal of the appliance which was given her. This is a lower arch. Still there are caries. Doctor, you can tell Dr. Which still caries is present. It is arrested caries. I did some protocol to make it arrested, stop then and there. We'll talk about it. And this is a recently. This is you can see the canine is gone. The premolar is erupting. Other side canine, everything you can see slowly, slowly. This is an upper arch. Presently approach. The moment this one thing that happened is after the first lockdown, when I saw her, I saw that 6 are getting infected. 6. I told the parents 6 are not genuine. So meticulously last October, after the first lockdown, we went for sealants for those 6 also, upper and lower 6, because it is not, because she's not maintaining early time, like every 45 days I'm seeing her, but now because of the lockdown, after 6 months and 8 months I'm seeing that's not right, because there is a risk. Told them, they accepted it. From this to this it has come. And yes, that's Friday, 2 days back. This is a picture. This is a picture with midlines almost coinciding, upper arch, and this is the sealant that I placed. I told you October I placed the sealant, applied fluoride varnish, everything is done for upper arch and the lower arch. This is after October. I'm seeing her in this July. I'm seeing her. This is a picture. Only one tooth is there to erupt. That is the upper canine. That's all. And we have taken X-ray. Nothing, no problem. It is erupting. It will erupt. I have created space for that. I just watch it. But she's wearing the appliance. Everything is normal and amazing. Sealants are still in place. Protection is going on. Fluoride therapy is going on. Everything is going on. From this to this, she has reached that. So it is step by step, protocol by protocol. Following is there. The last picture of her is like this, only the canine, and you can see the buccal bulge, and you can see the space. I don't have to worry, it will come normally. She's still wearing the appliance, the retention appliance she's wearing. So the midlines are perfectly joined, and I don't feel like putting a bracket onto her because they are so happy from what they were seen this. So the treatment plan was the preventive care, first and foremost. I am telling you again and again, why still her oral hygiene is poor. Look at this picture. Oral hygiene is poor. She is like that. Parents are like that. Don't blame, please. It is not possible. But still, she don't have any permanent teeth with caries or white spot lesion is because of this treatment plan, which I have told you. The treatment plan, the golden treatment plan, which you should follow there. Amazing, amazing result you can get there. And these are all interceptive part, which you do it properly. Here, slow maxillary expansion with 11 mm screw. So you have planned it. If you do 11 mm, you will get around 6 to 7 mm. Half, if the lab says I have 11 mm, half that expansion is possible in the dental arch. So the logic I applied there. So 11 mm gave me around 5 to 5.5. That was enough for her to do that. Lip and tongue exercises. That's very important. Tongue and lip exercises are very important. She did that, and that saved her from a extraction and ugly face to this. Just finally winding it up. I'm winding it up. One more case. Just winding up. Same condition, 7-year-old female patient. Same case, 7-year-old female case has come to me with complaint of tooth not erupted. At 7 years, they complain that front teeth are not erupted. So when I check the patient mouth, and they say irregularly placed tooth. That's when I check the patient mouth. This was a condition. The front anteriors are not erupted and lower anterior are irregular. This is the 2 teeth that erupted at the age of 7 years. Okay. So usual time of eruption, you know, but the teeth are not erupted. So I told them, why don't you take an OPG? Let me take an OPG. So I told them to take an OPG. All the 4 anteriors are intact, but teeth the permanent teeth are rotating inside, and the lower anteriors are erupted there, like you can see there. So fine, teeth are inside there. I told them specific treatment protocol, everything I told them, everything I mentioned to them, but they did not listen to me. They just did not listen to me. They came after an year. After an year, I specifically told everything. After an year, they came back to me with this condition. They were so happy that the doctor, the front teeth are gone. They are erupted. I said, yes, fine, fine. But doctor, we can see the teeth are coming out. Now the other complaint is the teeth are coming out. Early it was inside. Now they're saying the teeth are coming out. What? Yes, they are coming out, sir. So that is why we came to see you. Again, see, I'm a dentist. I have to attend their complaint and attended the complaint. So everything, told them the problem, all the things we did for her, all the things we did, the protocols, the interceptive and myofunctional protocols we did, all the functional analysis, soft tissue, the airway, everything we did for her. Everything was did for her. And what I found for her was the tongue problem. Tongue problem was again a retained infantile swallowing, which I told them is a reason, and it is happening there. And it was a complex tongue thrusting habit that was present in her. Told them, and they did not come again after 1.5 years. It has happened to my career. I'm telling you, after 1.5 years, the same patient came back. Doctor, now the inside teeth has come. Teeth is inside. So she is there from me from 7 years, 8 years. No, now she is almost 8.5 to 9 years. When that lateral incisor came, they are worried now. Doctor, whatever you said is happening now. Teeth are more coming out and teeth are coming inside. What can we do like this? So if you see lip posture, she's having a closed lip posture because everything is coming out. It's not a relaxed lip posture. Hypertonic lip is there. Everted lower lip is there. Mesocephalic profile. Symmetric, no problem. And this is that 8 years I told, that 7.5 years when they came, I told that there is a problem. Tongue thrusting, tongue is pushing the teeth. That is why initially the teeth was inside, but now you can see how much the teeth is being pushed. There is a problem that is developing. Everything is come out. They did not listen. Okay, they did not listen. The hyperactive mentalis activity, the function analysis. When I asked her to swallow, you can see perioral muscle are so much that they did not listen. So I diagnosed her as a complex tongue thruster, which is causing the teeth to come out and cross by because the tongue posture, everything is wrong for her. So told this is happening, but parents did not accept it. They are not worried because they are window shopping it. I know that window shopping it. They are going to other clinic, other people. They say, no, 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 this is 7, 8 years. Who's going to do? No, no, no. The child is going to wear the appliance. Who's going to wear this, blah, blah, blah. They started. They went and they filled that. And this was the condition there. And oral hygiene is poor. Gingival recession ratio 3:1 and 4:2. Caries index is again high. You can see multiple caries even with the thing, and even still active caries lesions are present. And there is a crowding that is present there. Midline is again, you see, deviated. Midline is again deviated so much. You can see that. Many people lose their confidence in taking up this case. They say, no, 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 13, 14 years. You can see that so many primary teeth is yet to fall off. Why want to treat? Who will treat this? No, no, no. Because they do not know this much complication. When the midline shifted, this is out. Oh my God, what a complicated thing. Don't dekha jayega. We can see it at the age of this and all. So if you talk about history, everything which I said, which I've told, analysis wise, you do a thorough analysis and find out what is the reason. So these are all secondary. These are all secondary. What you see in the patients, the overjet, overbite, what you can say in an erupting tooth, it is just erupting. You can't say because open bite also you can't say, but the tooth is erupting. How can I say this open bite is definitely when the central incisors, lower and upper central incisors go, there will be an open bite. So you can't say that is an open bite because this tooth are erupting. So that is not relevant at this point of time. But the point thing here is transpalatal width and the crowding that is present there. Transpalatal width and crowding that is not up to the mark. And there is a Posterior segment crossbite and a single tooth lateral incisor is also in crossbite. These things should warn you that. This should warn you that. You can take this again. I told you, canine. These are all little more 9, 10 years. You can take all those things and find out whether there's a chance of impaction or favorable position that is not required for this one. So you have to have a treatment plan now. This patient also required a good treatment plan. So a treatment plan. Final diagnosis of this patient is a 7-year-old patient, Vidya, was moderate crowding in the upper arch and the lower arch. Both are moderate crowding, having an end-tone molar relationship. Fine. Posterior segment crossbite on one side and a single tooth crossbite is there. Midline is deviated to the left, labally positioned 3-1 and 4-1 with gingival recession and reduced transpalatal width with no missing permanent teeth. Caries status is high, multiple active caries lesions still present there. Functional problem, retain infantile swallowing with hyperactive perioral muscle is present there. So again, you get a complicated thing, exactly like the other case. You got a complicated from where to start. Should I correct that crossbite? What about the gingival decision? What about the midline? What about the caries? See, protocol remains same, doctors. Protocol remains the same. Very simple. If caries actively, attend that first. At an early age, you have time. Attempt that first, and then goes into the appliance therapy, like an appliance or a muscle exercise. Now here you need more tongue exercises because tongue is complex tongue thrusting habit. So you need to modify the appliance or you need to train the tongue also along with the appliance therapy. Rest remains the same. So exactly the same thing is done for her. This is the 8-year-old picture, 7-year-old picture, and expanded the arch with the 2D expansion. Just that expansion, the arch. You can see the molars, the D's are all slowly exfoliating for her. The lower arch, slowly you can see the canines. You can see the premolars are guided. E space is utilized properly. This is her, this is her, this is her. This is her with a smile. Almost she is into 12 years of age now. This is the midline, which was so much variant. You can see the next picture, how the midline has come into normal, and is almost completely over now in the retention phase. 13 years in the retention phase from this to this you can attain. So what about the appliance? What magical appliance have we given? I did not give any magical appliance. It's a simple, slow maxillary expansion appliance I give. Expansion of the upper arch and the lower arch will follow. That is the principle by Dr. Graeber. So that is exactly I did. Meticulous follow-up, providing all other caries preventive aspect and removable short appliance. You think this appliance is not useful? Believe me, majority of the cases we finish with that. Now you can say that patient not wear. That is because your problem. You selected wrong patient. I will talk about it now. Slow maxillary expansion. Exactly expansion slowly at the age of 7 years to 13, 14 years, you can see amazing result. But there are modifications, there are requirements, there are so many phases which will come in this need to be do. You can make maxilla stable by expanding it slowly and soft tissue will adapt. Now you can apply egg or chicken. I'm not bothered. I know that it going to get crowded and completely constricted. So what I did, I expanded. So whether chicken comes or whether the bone or tissue comes, I'm not bothered. I expanded. I provided the room, rest, the nature took care. That's all. You expand, it is more stable. 1 turn or 2 turn depending upon age and condition we give. And treatment is usually the expansion gets over by 2 to 6 minutes, but you have retention. Retention requires some talk to about it. So this is the expansion. So put the screw and just ask the patient to turn. So 1 turn, that is almost 1/4 of a quarter of the turn. You tell them to do 2 days. That will give you a good expansion. That's called slow maxillary expansion there. And for those patients who has got infantile swallowing pattern, perioral muscular activity, or complex or simple tongue thrusting, I add a groove. I rarely keep a crib nowadays. I always put a groove so that the tip of the tongue can be rested or told the patient, and I give a color. I ask the patient, which is your favorite color? Some patient says, I am too much into green. I tell them to put that groove as green. Some patients say red or blue or yellow. This patient said, I love yellow. So told the lab people to put a yellow onto that groove so they can easily identify and relate, and they can keep the tip of the tongue at that groove and start swallowing it. So they mature into adult swallowing pattern. Tongue training can be done. No crib, no anything is given usually to make it less cumbersome for the patient there. So once the expansion is done, I tell seal it and hold it. That is called retention. Now comes the next part, retention. I keep this appliance for another an year or so till the canines erupt. So sometimes you might have to remove this and new appliance might be required. Tell the patient they accept a retention appliance I will give, or the same appliance, if it is good and hygienic and maintained well, same appliance is being retained till the canines are almost into occlusion there. Now, coming to the case which I said, Dr. Joby, you did nonsense for this case. This patient, before coming to me, went to 8 clinics in my area. They went everywhere. They said to wait. They could not manage this patient because everyone said, one is wait till 13 years. Second thing is you need to remove all the teeth, all the teeth need to be removed. So they tried to attempt to extraction first. Patient did not sit, jumped, throw the doctor, hit the doctor, went out of the clinic. Then they said there's another option called general anesthesia. We can do under general anesthesia, which the parents are totally dead against it. So they came to me. I saw it. Before that, my daughter told me, so, Papa, my friend is coming. Her entire teeth is bad. My teeth, she saw and she said, can you make my teeth also like that? Like an emotional attachment with my own daughter. I said, you tell them to come. So came to me. I saw it. So if I was like this, I would have definitely told that you need to extract that, then only I will start. I did not do this first. I started preventive protocol because I know that if those teeth are remaining there, what will happen? Hygiene maintenance, brushing maintenance, everything is fine. But my aim is to protect the permanent teeth first. So I applied fluoride varnish, everybody, and sealant varnish for the molars and everything I did. And nowadays silver diamond fluoride, which has come, which is an amazing product there. So that kind of total fluoride protection was given to her, took the confidence into her, which allowed me to take impression for her. So took an impression. That was a big thing. Parents were surprised. Oh, you did an impression for which was not possible. Yes. Then father will always ask me, sir, that bad teeth need to be removed. No, sir, it's bleeding. Yes, it need to be removed. Wait. So I put the appliance inside her. She was happy, confident. I started expanding. With this expansion, all those root stem automatically fell off. It automatically fell off. I got the space by itself, fabricated the appliance in such a way that all things got slowly shut off, and root remnants then and there was there, which we only removed it for her. We only removed it. She was happy because those removal was not with LA, which like spray. We removed it one by one. We removed it. We gave a total protocol. You can see no permanent teeth has got a white spot lesion there. If white spot lesion or caries is there, I am wrong. I'm wrong. I accept it, but that is not that. That was completely managed there. Nothing. She's still now. Still teeth are going on. Treatment is still in progress, but total management under your care is being done for her. And the turning sequence, the breathing exercises, everything. She was so motivated. She brings us the breathing exercises that she's performing, the tongue exercises she's performing. With the chart she brings and submit to us an assignment, and we make her king and queen of the, and she's almost done, but no caries lesion present there. So there is a protocol to be followed, guys, and if you follow the protocols for caries, meticulous step-by-step protocol is there, and planning is there. Functional analysis, there is a meticulous protocol. If you follow, there is nothing impossible for you to do it. If I can do, you can do that. and treatment plan. You know what is going to happen next. If you know, nothing to beat, nobody can beat you. So to conclude, let me tell you, proper parent and patient education is the first and the foremost important. Second thing is, have you selected the right person? There can be lots of controversy in that. Have you selected the right person or not? Either the patient is listening to you or not. And diagnosis and treatment plan, which I showed you, is meticulous. It is the cardinal thing. Once you get the blueprint, it's so easy to manage it. And appliance selection, I would have gone for a removable appliance and play around with the patient. No, so many times people give some appliance like a trainer, myobrace, or oral screen. This is for timing, this is good, and patient come back and says no improvement, so we spent so much money, no improvement, patient is not wearing, and nothing happened, all are out again. Please, we have seen each and everything. Selection, which appliance at that period of time is important. Lab prescription, how much expansion you want, what type of appliance you need to give, and follow-up and maintenance is very, very important. So if you are following a proper protocol, you know what you are doing, you will reach where you want. You can get the success in your cases. Otherwise, you will be roaming around like this. This patient will be from one dentist to other dentist, from your senior to junior, junior to senior, that dentist, this dentist, keep on rotating. No end will be there. So guys, thank you so much. If you have any more doubts, you can reach me in this. Thank you so much, and thank you. We are having a excellent 1 full day session on whatever I discussed today. Extensive session, step by step, at least one habits you will be the master, and management with model analysis, with cost analysis, with self analysis, with everything proper. 1 day, 7 to 8 hours. So join us. Do not reluctant. This is a Malaysian degree. That's an amazing platform they have given us. So we will be giving the best, and I hope to see you all there. And thank you so much for your patient listening. If any more doubts regarding to the case discussions, I am ready to address the questions there. Dr. Binu, Dr. Joe, are you there?
Yes, Dr. Joby, thank you very much. There are some questions. Let me take that quickly. How to select the screw sizes?
Yes. Regarding the screw sizes, doctor, you need to know the transpalatal width and how much crowding is present. Depending upon that amount of crowding, you decide whether you need a screw of 9 to 10 mm. There are screws for maxilla. There are screws from 11 and 14. There are only 2 screws for maxilla. Leone, that Italian company, Leone, has got 2 type of screw, that is 11 and 14 mm. So mild to moderate, you will always go for 11 mm. A screw of 9 to 10 mm. Okay, you go for that screw. A little more, you can even go for 14 mm. For mandible, again, screw size varies from 9, 11, and 14. Dr. Binu?
Can please tell about breathing exercises?
Again, breathing exercises, there are 5 to 6 breathing exercises, starting from breathing, the correct posture breathing, into alternate nose breathing, into butico breathing, into deep breathing exercises. So all these are exercises where you breathe, but your shoulder or neck and shoulder doesn't move or doesn't take part in your breath. So posturing the patient first properly, posture the patient properly with good support, and tell the patient to take a deep breath. When the patient is taking a deep breath, there should not be any shoulder movement, chest movement, or neck and shoulder muscle should be there. It should be all the diaphragm should be moving. So you should observe that. And alternate nose. If you inhale through one nose, you exhale through the other nose. Then you inhale through that nose and exhale through that. And butico breathing, which require around 15-20 minutes of practice. That's one of the beautiful exercises that you can do. Butico breathing exercise.
Can you please tell the sequence of RME rotation?
RME. Oh, Dr. Biri, is RME or SME?
RME.
Oh, RME. There are so many protocols for RME. I follow Zimmer and Isaacson protocol, where 2 turns per day for 5 to 7 days, followed by 1 turn per day for next 7 days. And that also varies depending upon each conditions and cases. So Zimmering and Isaacson protocol is one that I follow.
How to decide whether maxilla is narrow?
One way is transpalatal width. There are so many other ways, like Kuroko's palatal height index. So many things are there where the maxilla is narrow. One way is the simplest way, which I told you, is according to Dr. Graeber, is transpalatal width. Anything less than 35 in a mixed dentition is a constricted narrow maxilla.
Can we treat tongue thrusting after 20 years?
100%, 101%. We can treat at any age tongue thrusting, provided there are no neuromuscular problem like Down syndrome or attention deficit hyperactivity or some kind of neuromuscular disorder is not there. You can completely cure, convert into adult swallowing any age group. But if this neuromuscular problem is there, then you can only improvise it, tune it depending upon the neurological development there.
As a matter of fact, Javi, I think it's easier to treat after 20 years because they know
Yes.
exactly what you're talking about and they understand exactly what you're talking
Yes.
about. 10 times in the morning, 10 times in the evening, that exercises which you tell, if they do standing in front of the mirror, if they do better than kids. So as a matter of fact, this is easier to treat an adult. Am I right on that?
Yes, sir. Yes, sir.
Now, how to diagnose retained infantile swallow?
Oh, okay. Now you are talking about simple tongue thrusting and complex tongue thrusting. It's other way around. We can put it around. Simple tongue thrusting is a one where there is only the perioral muscles are very active, and there is no much involvement of your tongue or your other muscles there. In complex tongue thrusting, all the facial muscles are so hyperactive. The masticatory muscles are totally not involved. They are like they don't have any action. So if you check for the masticatory muscles like masseter activity, if there are no masseter activity and full perioral muscle is controlling, that is a complex tongue thruster. But other way around, you see that some amount of masticatory muscular activity is there, but only problem is tongue is little placed forward and little bit amount of perioral muscular activity is there. That's a simple amount of tongue thruster, easy to break. But complex tongue thrusting, you need more amount of training there.
RME and SME, how to decide?
That is the next. We having a one full day session on RME and SME. That's a elaborate topic, doctor. It depends upon the facial analysis, depends upon the model analysis, depends upon the cephalometric analysis, the soft tissue analysis. So many things decides whether I can do RME or SME. So many times we do an RME for a patient who does not have any crowding arch, but all are behind, like skeletally they are not up to the front part. So all depends upon the conditions there. So if you ask me, like conventional method, if you ask me, if you have crowding more than 6 mm, RME is indicated, I can tell, but not always like that. So many other conditions also we prescribe RME for that particular situation.
Not very relevant questions. 9-year-old pulp exposed E, better treatment plan, extraction or pulpectomy? Pulpectomy.
Yeah, would be if pulp is exposed, if you can save, if the tooth structure is sufficient tooth structure is there and root development, no resorption, then you can opt for it, doctor. It's a choice on the chair choice with clinical observation and IOPA. If clinical observation sufficient amount tooth structure is there, IOPA says sufficient amount root length is present, definitely you go for pulpectomy. If patient and parent are not willing, extract and at least give a space maintainer.
So what to do in an 8-year-old patient with gingival smile and open mouth?
Doctor, gingival, that is what there are so many cases. Remember today in the clear aligner class also I shown that Aditya, who's 9.5 years old with such a gummy smile, and he is into 15 years. We how controlled that gingival smile. So you need orthopedics. You need to find out the maxilla is excess positioned normally at that point of age, or excess maxillary or protrusion, or tooth is proclined. All those things has to be rolled out. If you find maxilla is positioned, then posteriorly, that is the reason for that gummy smile or that gingiva has been seen, then you need to use MIS, or you can see maxillary intrusion splint with headgears and all those things, the cervical pull headgear and all those things need to be applied. So you're talking about an orthopedic problem here, and that can be analyzed early, treated early, properly, and can be controlled well nicely if you apply the right appliance at the right time.
Another question here is, maybe I will answer to give you a break. Is it possible to do any maxillary arch expansion after 20 years?
Please, Binu.
You can do maxillary arch expansion after 20 years, but understand that the mid-palatal sutures are all closed. So opening up the mid-palatal suture at the age of 20 may not be easy. So you have two choices here if you want to really split it open up. One, mini implant assisted rapid palatal expander. Again, how far it can open up the suture, doubtful. Then SARPE, surgically assisted rapid palatal expander, would be the way to go when you want to really open up a completely fused mid palatal suture. Can fluoride be applied on deep carious lesion?
No way fluoride can be applied onto the deep carious lesion. If you apply it, you might end up in pulpal response, especially APF or acidylated phosphate fluoride varnish there. So there is a protocol called, you temporarily seal it. If it is a deep carious lesion, before applying the fluoride, take an IOPA, see there is sufficient residual dentine thickness is there, sufficient residual dentine thickness, RDT. If it is there, then I suggest you go for a temporary restoration, non-hygienol temporary restoration like cavitum and all. Wait for 2 to 3 weeks and remove it, and then you apply fluoride, and then you can go for a final restoration. So it is called heal the carious lesion and fill it.
Dr. Pavani, our constant follower. Thank you so much, Dr. Pavani, for coming in. Her question is how to diagnose hyperactive mentalis.
So hyperactive mentalis, one way is to simply ask the patient to say the word M. Okay, M, or you can say Mysore, or you can say Mississippi. Tell the patient and swallow. Ask the patient to swallow. So whenever the patient say this word M, it will be okay. But ask the patient to swallow. You notice the perioral muscle. The perioral muscle, if it is contraction is present, orange peel appearance or tightness, if you see on the perioral muscle, that means it is a hyperactive mentalis that is present, which could be a retained infantile swallowing pattern, which cannot be a complex tongue thrusting because the masseter is also active there. If only this is active and this is not at all in action, that is a complex tongue thruster.
Aravind Mohanan from YouTube. Which fluoride varnish do you use, sir?
I use Fluoritop and Vocos MI varnish. Also, I use it very regularly. That is wonderful, working out good. But protocol, I said, depending upon the caries status, I don't think that every fluoride varnish has to be applied once in 6 months. No, ADA and AAPD also recommendations are different. Depending upon the caries activity and status, you need to increase the application of fluoride varnish once in 3 months to once in 6 months. That protocol you have to follow.
All right, we are done. Still some questions unanswered because I missed in the chat box or in the YouTube. Please come to the WhatsApp groups you are in. It will be definitely answered. Thank you so much, one and all. Thank you so much, Dr. Joby, for meticulously planning those two cases and presenting it in such a way that, as we said in the beginning, it represents almost 25% of the malocclusions you see in pediatric cases. So you just help them understand, diagnose, and treat more than 25% of the pediatric malocclusions you see in daily private practice. Thank you one and all for coming in. Please stay tuned for lots of stuff coming up next Sunday, full day. Understand it is Malaysian time, early morning, 7 a.m. Indian time, you got to be there. Please register early, seats are limited for that. Those who are interested, please register at the earliest. You are going to get loads of information regarding pediatric malocclusion, and you also get a international certificate from Faculty of Dentistry, Lincoln University, Malaysia. With these words, let's call it a day. Thank you very much, Dr. Joby. Thank you very much, Dr. Gobu, Dr. Dean, Dr. Pushparajan, sir, for coming in and staying so late. It's in Malaysia. It's really late, I know. Thank you very much, one and all.